I'm Peggy Schmidt, and it is my privilege as North Kansas City Hospital's President and CEO to welcome you to today's presentation, Get Your Back on Track. The phrase back pain is consistently one of the top search terms that we find on our website. Nearly 80% of Americans will seek medical care for back pain at some time in their lives. Many back injuries are minor and can be treated fairly conservatively, but chronic back pain is different. It develops in about 20% of people with back pain, and it creates issues for performing their general activities of daily living. We are very delighted that we have Dr. Reintjes Jr. with us today. He is a neurosurgeon with Veritas Health Neurosurgery, and he's going to share his expertise on chronic back pain with us. Dr. Reintjes received his medical degree from the University of Missouri, Kansas City, and then he completed a 7-year neurosurgery residency at the University of South Florida. During that time, he did a 1-year fellowship in epilepsy at that college, and then did a 1-year neurosurgery fellowship at the Swedish Neuroscience Institute in Washington State. Please join me in welcoming Dr. Reintjes.
Thank you, Peggy. Can everybody hear me okay? Okay, good. Like Peggy said, my name is Dr. Reintjes. I'm Dr. Reintjes Jr. Dr. Reintjes Sr. is actually my father, and he's a practicing neurosurgeon in North Kansas City, so I'm sure many of you know that. And today I'm going to talk about chronic back pain in conjunction with our physical therapist that we have at North Kansas City Hospital. So, whenever our family, I'm sure some of you will go on vacation this summer at some point throughout the year, but whenever we go on vacation, we have to have an itinerary for our family, and that is because if we don't, then everybody will fight and bicker about what we're going to do next. And so we have to have an itinerary. And because we're Irish, this is going to be a little bit of an Irish itinerary. But what I'm going to talk about today, I'm going to try to keep it to this agenda and kind of sort of like an itinerary for the summer. But I'm going to talk about epidemics of back pain. We're going to talk about the causes of chronic low back pain. I'm going to talk about some of the non-operative measures that we employ. Kristen will come up and she'll talk about our Move Plus clinic that we have at North Kansas City that we've created over the last 9 to 10 months. Then I'll go through some of the surgical preparation of patients we find that they are a candidate for surgery. I'll go through some of the new minimally invasive techniques that we use. And then we'll talk about what we do after surgery and how we recover patients faster. And finally, if all else fails, we'll talk about if we get to surgery and patients are still hurting, what we do next. So you probably have noticed around town and around the country, there's an emphasis for outpatient surgery centers, and especially with orthopedic care. And with neurosurgery, we're trying to get there, but we're not quite there yet with the drive-through brain surgery. Okay? I actually don't know if I'll get there, and most of our procedures are not appropriate for surgery centers, but it's a lot. And we don't operate out of a surgery center with our group. But I thought this was a funny cartoon and kind of appropriate for all the surgery centers that you see pop up around the city. So this is a slide which demonstrates kind of the burden of back pain and the disability it causes. This is from the IHME, which is the Institute for Health Medical Economics, Health Metrics and Evaluations as well. And this is in the United States, and this is in 2015 for both men and women. And this just gives us an idea of all the years lost due to disability. And you can see back pain and neck pain have an outsized proportion of years of life lost due to disability. In 2015 alone, 12.5% of all disease was related to back and neck pain. And that just gives you an idea of how common these problems are. And most people, like Peggy said, will experience back and neck pain at some point in their life. And so this is why it's so important to study back and neck pain and see how we can fix it and how we can treat it. To get people back to better, get them back to functioning and back to the activities that they like doing throughout the day. This is actually created, this Institute of Health Metrics and Evaluations is what the World Health Organization uses to study the global burden of disease, and it was actually created by a resident at Harvard back in 2010. And I don't want you to read all this slide, but this kind of goes over just kind of all the different causes of back pain. I mean, there's so many causes that when a patient comes into clinic, we really have to think about, go through the checklist in our mind. Is it one of these causes? Go anything from anywhere from anything structural to stenosis to tumors to hematologic to musculoskeletal, visceral tumors, nerve compression, anything. So most of our patients, when they come in, most of them have a structural problem. They either have a problem with instability or discogenic pain or facets, or they usually or a slipped disc or something like that, or stenosis where there's pressure on a nerve and you have to go for relieving pressure on the nerve. But really, this just kind of gives you an idea of all the different kinds of causes of back pain. So we really have a challenge when someone comes in with chronic back pain. How do we treat it? How do we get them better? Now, not only do we have the causes of back pain, the structural causes, the infections, the tumors, the discs, but we also have the etiologies. Because not only are we dealing with physical barriers to pain, we're also dealing with mental barriers to pain. So some people come in and they have behavioral problems. They are a hard worker, their back hurts because they go to work every day and they work hard and they're lifting objects and their back hurts because of that. Sometimes we have neurologic causes that, like I talked about, we have pressure on the nerves or slipped disc that we can treat. Physiological is the same way. Sometimes people have some instability in their spine, so when they stand up, their spine is moving and that causes a lot of pain. The hard thing about treating back pain, though, is sometimes there's a lot of cognitive, motivational, sociocultural, and psychological causes of back pain. And those are not as obvious. Those do not show up on a physical exam. They don't show up on any imaging. And so sometimes it's really difficult to parse out, well, what's causing pain, what's kind of the cognitive, what's the motivational problem, and what's actually a problem going on with this patient's back that we can fix. So that's another part of the equation that's really difficult because these kind of four on the bottom, these etiologies don't really show up very easily, and sometimes we can be feared. So we really try to take our time, go slow, and try to really understand the cause of etiology in these patients' pain. As we know, most patients who have chronic low back pain, they kind of cope with it on their own. They take medicine on their own, or they know what causes the pain, they know what makes it worse, what makes it better, so they kind of avoid those behaviors and those activities. And most of them do not say to you. If we saw everybody who ever had back pain, we would never be able to do anything because our clinics would be so overloaded. So a lot of patients, and maybe a lot of you are just, they say, I have back pain all the time, it doesn't really bother me, and I'm kind of okay with it. And that's okay. The treatment is really affected, and Kristen will talk about this with therapy. Treatment is really influenced by the patient functioning, whether it's a physical problem or not. And then as we've studied back pain, no treatment modality has shown superiority over another, whether that's rest or medicine or physical therapy or pain management or surgery. No one modality is better than another for chronic back pain. But it's really important for us to assess whether a single approach is the appropriate, is the cure for pain. And by single approach, I mean whether the patient comes in, is surgery the answer, or is physical therapy the answer, or pain management. Oftentimes it's not. Oftentimes a single approach is not the best way for treating back pain. And so when patients come in and they say, I'm hurting, I want surgery, well, we really have to take a break and pause and say, is surgery the best thing for this patient? And then kind of this multidisciplinary biopsychosocial rehab is kind of a fancy term for our Move Plus clinic. And it's an umbrella term for all these clinics which incorporate not only physical therapy, but kind of a holistic approach to treating back pain. And that remains a viable option and is an important option for us at North Kansas City. So we've kind of talked about this a little bit, the non-operative measures, and I'm sure most of you are familiar with some or all of them. We have rest, medicines, over-the-counter medicines at home. Sometimes short-term pain medicines are very beneficial. I don't ever condone long-term pain medicines. Physical therapy is definitely an option. Physical medicine and rehabilitation and evaluation by a doctor as well. Like I said, Kristen's going to talk about Move Plus, and then pain management has their bag of tricks with injections and ablations, nerve blocks, etc. And then we kind of get to the alternative treatments, which for some people find it very beneficial, like acupuncture, yoga, Pilates, Tai Chi. A lot of patients come in and ask me, well, can I do acupuncture? Can I do yoga? Is that going to make my pain worse? Well, most of the time they don't. If something causes worsening pain, I always recommend that you stop that activity. But a lot of times, these alternative treatments are very helpful for people. So I encourage them. Notice one thing on here I did not list was chiropractic care. Some chiropractic care I think can be good, but also I've seen a lot of patients who their symptoms get worse with chiropractic care, so you just have to be careful. And there are many rehab treatment options, and I'll kind of skip over this because Kristen will cover it. But there are many options for low back and neck pain, and obviously the outcomes vary. But a lot of it is based on patient education. What we want to do is not only strengthen the core with exercises in light weight training, but we want to make sure the patients are sitting up straight, they have good posture, and they modify their activities. So if they have pain at work, but they're sitting hunched over the computer all day, you might ask them to get a standing desk and kind of modify their behaviors at work or at home or whatever's causing the pain. And that's a really big part of what we do and how we have the physical therapists help us with that. But all my patients come in always talking about posture. A lot of us today, we all have cell phones, and so we're constantly looking at Facebook or Twitter or pictures of our family, and we're constantly like this. Well, that can cause a lot of neck pain, especially in the surgeons who are working, looking down all day. So we have to be really careful about our posture. It's really important. And then there are other modalities, soft tissue mobilization. You see this patient's getting massage, traction, electrical stimulation, ultrasound. Those are all different modalities that pain management colleagues use and physical therapy colleagues use. So again, Kristen's going to talk about Move Plus, but this program is designed to reduce pain and improve function, which is the goal of patients with chronic pain. It is individualized, but uses a group-based format. We incorporate education and quota-based exercises. And this is coordination between North Kansas City Hospital, our physical therapists, our director of rehab and physical therapy, and the neurosurgeons at North Kansas City. And so it's a really nice collaboration because we can talk back and forth about patients, and we can really kind of get down to the nitty-gritty of what can make this patient better. And this Move Plus and this biopsychosocial rehab is evidence-based. We've studied this. The Cochrane database is a huge database of all the studies that have been done around the world for whatever disease, whether it's heart disease or diabetes or cancer. And we've done analyses and reviewed 47 studies and had over 7,000 participants. And that we know that these clinics like Move Plus have a more positive effect on pain and disability outcomes than does the standard of care or other physical therapy programs. That's why when a lot of patients come to me and they say, my back hurts, I've tried everything, I've been through physical therapy, I've been through pain management. I say, well, you've been through physical therapy, but you haven't tried this, you haven't tried Move Plus. And a lot of times I'll send the patients there and they say, you know what, I don't want to. I say, well, do this. For me, for you, just go try it. We'll see how it goes. You don't have to continue with it, but just go try it and see how it's different than normal physical therapy, because I can promise you a lot of patients will find a benefit where they didn't have a benefit with regular physical therapy. Also, we can have a beneficial effect on work outcomes with this biopsychosocial rehab. And we also know that it's not for everybody. Some patients say, it doesn't work for me, it's not helping, there's something else going on, and that's okay. But it really helps those with physical or psychosocial factors going on. A lot of patients who are laborers, who have working jobs, where they're using their hands, lifting a lot of weights all day or heavy objects, this is a really, really good option for them. A lot of times when patients, so we go through that, and now patients in clinic, and oftentimes when you come to the clinic, and if you come to my clinic, you'll see this exact figure. This will tell us, we want you to draw where your pain is. We can't help you if we don't know where your pain is. And the best information you can give us is tell us exactly where does your pain hurt. Does it hurt in your low back? Does it go down your leg? Is it in the front of your leg? Is it in the back? And then we have different markings. You have weakness or numbness or tingling. And so when you come in, these are really extremely important for you to fill out and fill out accurately. A lot of times, actually, you'll probably see a visual analog scale, and this is kind of a numeric rating system where you will actually rate your pain. If you don't see these in clinic, a lot of times we'll ask, well, rate your pain. Tell us what it's at today on a scale of 10, 10 being the worst. And a lot of patients come in and say, it's a 15. You say, no. On a scale of 10, 10 being the worst. I'm sorry, guys, I don't think you delivered a child, so I don't think it can be a 10. So just take that in, take that with a grain of salt. But there's lots of different analog scales. I'm sure everybody's seen this if they've been in a hospital or a doctor's office. We often see this and try to rate our pain. That's also a really important clue. And so a lot of patients who come in also have had previous surgery, and for those patients, we really have to take a detailed history to figure out what's important. We have to really reconstruct the patient's history to get better detail. We want to know, when did you have surgery? Where was it done? What levels of your back did you have surgery on? Where, what facility, and what was the indication? What were your problems at that time? Were you having back pain, were you having leg pain, were you having both? And do you have any instrumentation? And that is really important stuff for us to know. And so that's why a lot of times the patients who've had surgery for it, they take a little bit extra time to kind of parse through all that history. We know revision surgery is a higher risk. Once you alter the anatomy and scar tissue forms, it's really a challenge to go in on a patient who's got a previous surgery. It's not impossible, we do it often, but we really, again, have to be careful and take our time with surgery. And then really have to emphasize a team-based approach. Oftentimes patients have had surgery before, have a lot of factors contributing to their pain, whether it's psychosocial or it's physical. So we really have to use a team-based approach. We use our pain management physicians and our physiatrists to help us. And also for the surgeon, it is physically and mentally demanding. So we really want to focus, and we really want to make sure that we're giving the patient our best attention during surgery. And also, just remember that revision surgery or surgery is not the answer for all problems, especially if you've had surgery before. Sometimes it can really help and you can have a dramatic result and dramatic improvement, but surgery is certainly not always the answer. And then once you come in and you see us and we'll talk about surgery or talk about the next step in the treatment, oftentimes there's imaging. Unlike many other specialties, neurosurgery is a high imaging specialty. So whenever there's a problem, we want to be able to see it. And we want to see it probably on more than one modality. So oftentimes they'll come in and go have an MRI, and we may order a CT myelogram. Oftentimes we'll order x-rays to look at the bones of your back, because the MRI tells us about the nerves and the discs and the ligaments really well. But it doesn't tell us much information about the bones, and that's where the x-rays and the CT scans are really helpful. Sometimes if a patient has a deformity, we'll get scoliosis x-rays, we'll actually take an x-ray that is 3 feet tall, and it's really from your neck through your hips to tell us what is the global alignment of your spine. How does your spine look when we look at it as a whole? Because oftentimes we can't just take one segment of the spine and say, we're going to fix this. We have to look at the whole spine and say, well, your problem is actually a little bit bigger, or it's a little bit smaller than what we thought. And so that's why we get scoliosis x-rays. And then the DEXA scan is really important. If any of us are entertaining a fusion or putting in hardware, we really want to look at your bone health and the quality of the bone, because we want to make sure your bones are strong enough to heal after surgery. And obviously, we want to make sure that in preparation for surgery, we make sure that you are you have optimal nutrition. And I don't mean eating this super Big Mac every day and you say, I'm good, I have 3,000 calories a day and I'm good. We want to make sure that you have the appropriate amount of calories, but the appropriate amount of the breakdown between carbohydrates and proteins, and as well as fats, because all those are going to help your body heal after surgery. For patients that smoke, I make them stop smoking before surgery because we know that smoking decreases our healing rate by 50%. And so those patients who smoke are going to have a harder time recovering. They're not going to heal as well. They're going to have more wound problems. And so smoking is really important for us to stop before surgery. Even then, I make patients stop 6 weeks before surgery. Why? Because when a patient has smoked for a long time, as soon as they stop, they get sick because they get a buildup of all this gunk that comes up from their lungs and it gets stuck in their throat. And so it really takes 4 to 6 weeks for that to clear up. And we don't want to operate on them, and the anesthesiologist doesn't want to put them to sleep if they're coughing up a bunch of stuff from their lungs. And so we really want to wait a few weeks after they stop smoking before we operate. And then counseling. We need to make sure that everybody's on the same page. The patient, the family, the surgeon, the nursing staff, the hospital are all on the same page in regard to the procedure. We have an idea of what's going on. We have a problem. We have a potential solution. But here are the risks. Every surgery has potential risks. And we make sure that everybody understands that every surgery has those risks, and also that there are alternatives and benefits to surgery. So patient counseling is really important. A lot of this is taken care of in the clinic before. So once we get through all that, you can see most of my talk is talking about preparation for surgery, alternative therapies, physical therapy, Move Plus, and then the surgical preparation, imaging, nutrition, smoking. So all that goes on even before we get a patient and say, surgery's right answer for you, let's proceed. So it really is a long effort to get a patient to surgery because it is such an important problem for us to face. And we will make sure that we're doing the right thing for the right person at the right time. And so really, we take our time and really like to understand exactly what's going on. So now we've gone through all that, and I'll talk about a few minimally invasive techniques, which are the newer techniques in surgery that we offer, and then I'll turn it over to Kristen. But the goal of minimally invasive surgery is really to minimize soft tissue damage, minimize damage to adjacent nervous and vascular structures, less blood loss, less postoperative pain, smaller incisions, shorter hospital stay, and a quick recovery. That is basically MIS surgery in a nutshell. But really, what's really important is the outcomes have to be similar or better than open conventional surgery. And not every patient is a good candidate for a minimally invasive approach. So the 4 pillars that we use, and this is more for surgery, but we use kind of a microsurgical technique. So oftentimes we're using a microscope to see the structures a little better. We have developed new access strategies to the spine instead of the straight midline posterior. We have other access strategies. We have new imaging and navigation techniques, and we have new instruments and implants. And so those are all kind of things that lead to MIS surgery. So again, smaller incision, less damage, less blood loss, lower complication rate, less scarring, quick recovery, and quicker return to activities of daily living, whether that's golf or gardening or playing with kids or grandkids or whatever it is. This is the goal here, and MIS surgery can certainly offer that. Importantly, we have to know our limits. This is actually a young patient. She was 25 years old. Unfortunately, I think had an IV drug use problem, and she had a collapse of her spine, a complete collapse. There's no solution for this that is minimally invasive. This is a big surgery. And fortunately, we were able to stabilize her and get her upright, and she walked out of the hospital about a week later. This is a dramatic problem that requires a dramatic solution, and this is not a patient that needs minimally invasive surgery. I'm sorry, there's no way around it. But this is not the patient who we're talking about. There's been kind of an evolution over the years. You can see, I know this picture is small, but you can kind of see this big 8-centimeter incision that's open. You can see the muscles, and we still employ this quite a bit, okay? This is still an option for us, and we still use this. But as we've evolved over the years, we kind of get a control open, then we get a mini open incision, then we use these percutaneous tubes to operate through, and eventually we can operate through a very small incision. So And minimally invasive decompression is kind of the mainstay, kind of the hallmark of what we do. We operate through a tube and actually put these sequentially dilating tubes down. So actually what we're doing is, as the tubes go down, they get bigger and bigger and bigger. So if you're not cutting any muscle, we dock the tube on the bone, on the spine, and the muscle just dilates out of the way. And we do our operation, and when we pull the tubes out, the muscle comes back. And so that's part of the reason why we're not causing as much pain, because we're not cutting as much muscle as we do with open surgery. So usually we have an articulating arm that is attached to the bed, and then this tube, which we operate through, which is on the patient's spine. And we have to use a microscope to see down there. So this is kind of a schematic of what it looks like. This tube is docked on the spine. If you have stenosis or herniated disc, this is a really good surgery. This is kind of what it looks like on the x-ray in surgery. And this is kind of a picture of what it looks like when the patient's asleep. You can't see much. That's why we have to use a microscope and use x-rays. It's really important. But when we're done, you can see the incisions are pretty small. And if the patient's getting better, that's a really good thing. Yeah, and I found that when I trained in Florida, MIS techniques were really important because patients were really concerned about the bikini body or being on the sun, the skull, and things like that. So, you'd come into surgery and the patient said, I want a 1.5 centimeter incision. And I say, well, sorry, you can't do that. We'll make it a little bit bigger, but we'll make it as small as possible. So in Tampa, where people kind of worship the sun, they really get excited about their back incisions. I haven't found that to be as big of a problem in Kansas City. But we can have great results. This is a patient with a herniated disc that's migrated inferiorly from the L4-5 interspace. This is the L4 vertebral body. This is L5. The patient had a herniated disc that migrated down. Using the tubular retractor and a nice technique after surgery, we can remove the disc. And actually, this patient had a great result. We resolved their leg pain, and they were able to go home the next day. When we get to some of the bigger surgeries, we can also use minimally invasive techniques. This is a patient which is having a fusion and having instrumentation put in for stability. Okay, we use, again, you can see this tube here docking on the spine, and these guide wires are in the pedicle and to help stabilize the spine, and then we put in an inner body. Okay, again, this patient did very well. And usually these patients can go home in a day or two. This is again a laminectomy fusion using minimally invasive technique. See, they have a stenosis and a little bit of a slip right here at L4 on L5. And using a minimally invasive technique, we can bring the spine back into alignment and also decompress the spine, and all the stenosis looks much better at this area. Okay, so the back pain and leg pain resolve, and the patient goes home in a day or two. Some of the newest technologies focus on, those technologies are direct decompression, where we're seeing the nerves, we're directly decompressing them and stabilizing the spine. Some of the newest techniques are actually indirect decompression. We're not actually decompressing the nerve directly, but what we're doing is we're actually lifting the spine up. So this is a patient with a degenerative disc that has stenosis here. And what we're doing is putting in a graft in here to kind of, for lack of a better term, mudjack and lift up the spine and restore the height of that disc. And what we find is that the height of the disc here compared to here is much different. The height here is much better. And what does that do? Well, it stretches all those ligaments and everything, and the patient's radicular symptoms or leg pain goes away because it's stretching those nerves. And we're not actually seeing the nerves, we're actually putting this in from the side. And so that's why we call it indirect decompression, but it can cause a significant difference in the patient's pain. Again, with these lateral inner body techniques, where patients are having surgery from the side on the spine. So we're not cutting any muscle, we're just dilating muscle, and so the recovery is much shorter. So the advantages are, it's an indirect decompression, but less tissue damage, restores the height of the disc, we talked about that. Blood loss is usually minimal in these procedures. The graft that we put in has a large footprint, so it extends the whole width of the vertebral body, and there's a lot of support for this spine. There are disadvantages like every procedure. There's a risk of damage to the nerves, even though we're not directly seeing them. There's a risk of damage to vascular or visceral structures, and there's a steep learning curve with these procedures, and so you want to make sure that whoever's doing these procedures has a lot of experience. The anterior inner body is also a procedure where you make a small incision in the abdomen and access the spine from the front. Again, it's an indirect decompression. We can restore height that way. Some of the kind of the most technically advanced are lateral thoracic surgery. So previously, if somebody had like a thoracic problem, a herniated disc, they need a cardiothoracic surgeon to make a big long incision in the side and deflate a lung, and then we do the operation and they would close up. Now we use a small incision, one surgeon. We don't use a cardiothoracic surgeon. We use a targeted approach. We have a small incision. We use a retractor here to retract all the structures out of the way. We can access the spine, whatever pathology is here. This kind of is a cartoon showing exactly what we're doing. And this is a spine from the side. But really, it's a great technique and allows us to be able to treat thoracic spine problems without another surgeon, which decreases the time in the OR, decreases anesthesia, and then a complication. So certainly, it's a nice thing to have. And this patient is a 47-year-old female who had a big bone spur pressing on her spine, but you can't see her spine, but it's right here. And using this lateral thoracic technique, what we do is actually resect part of the rib. We come in from the side, and we can have a dramatic result. All that bone spur is completely resolved. Her pain got much better. She was walking better, and she left the hospital a few days later. So she did really well. Kind of lastly, for patients with fractures, you can see this is a 53-year-old female who had a seizure and fell. She has a fracture of the L4 vertebral body. One of the things we can do is do percutaneous pedicle screw fixation. So in order to stabilize the spine, we'll actually put in screws through L3 and L5 through the skin. So we make a small stab incision, put the screw in, so the patient will have actually 4 small incisions, but they're each about 7 mm length. So it's really a dramatic change to what we used to do and have to make a big long incision for something like this. And this is something that can get done in about an hour or two, and patient can go home in a day or so. It's really dramatic to me. Very similar, a 30-year-old in a car accident has a thoracolumbar fracture right here that was unstable, and we can stabilize it by putting just a screw in above and below. We don't reduce their, we don't give any motion saving abnormalities in the spine. They really don't notice it once they heal. They don't even notice that anything is there. And it's a small incision, and they can go on in a day or two. So that's kind of a quick rundown of some of the new minimally invasive techniques that we're using. I know there's probably a lot of medical jargon, but there's a lot of different options we have now in regards to surgery. And I think minimally invasive surgery is a tool. It's a really important tool. It's not the be-all, end-all, but it's something that we can really incorporate into our practice. Lastly, I just want to briefly go over what we do after surgery. So when patients come through a clinic, they have surgery, and after surgery, how do we get them back on their feet and functioning quicker? Well, we have a program called Enhanced Recovery After Surgery. And this is partly program, but partly a movement that developed in Denmark in the 1990s by a couple GI surgeons. And what they found is that after their GI surgery, the patients were in the hospital for weeks and weeks and weeks and had a hard time waking up their bowel and things like that. So they wanted to find a way to optimize the perioperative care. So what this is reduces the metabolic stress of surgery, lessens inflammation. The goal is to maintain fluid homeostasis. But also it takes multiple providers. It takes the anesthesiologist, it takes a surgeon, it takes a nursing staff to integrate the postoperative care. And we always are looking at our data to see how we can make this program better. So it's a constant data-driven quality improvement approach. So if a patient comes in, a lot of my spine patients have enhanced recovery after surgery now. You'll notice that we have some interesting medicines. So we have these medicines in the preoperative area, and then we continue them after surgery. The other thing that's really important, we talked about nutrition earlier, patients have to take an impact protein supplement for 5 days before surgery. That is to help increase their nutrition immediately before surgery. And on the day of surgery, we actually don't have them go to surgery while they're fasting. I don't know about you, but I don't do anything well with an empty stomach. And I'm sure your body doesn't heal well on an empty stomach either. So we actually have them drink a clear fast, which clear fast is kind of a fancy Gatorade that has a lot of electrolytes and some nutrition in it before surgery, in order so your body's not being worked on while you're on an empty stomach. So Also, we try to avoid during catheterization, and then after surgery, we give you several medicines in the post-op period. We give gabapentin, sometimes often use narcotic, IV Tylenol, and then we often use Toradol, which is an anti-inflammatory. And then the other important thing is early mobilization. So even after spine surgery, especially if you have surgery in the morning, we want to get you up and walking that day. We want to get you moving. 20, 30 years ago after surgery, after spine surgery, you'd have to lie down, kind of stay in bed for a few weeks after surgery. But now we want you out moving. Okay, I think that leads to better outcomes. And this is talking about enhanced recovery. This kind of tells us when patients who have enhanced recovery protocol versus non-enhanced recovery protocol, you can see the hospital time is much shorter than down here. And also the insulin sensitivity and the tissue damage is much less. It stays much closer to homeostasis, whereas traditional surgery without it, we kind of go way out of whack. And that's why a lot of patients after surgery, their blood sugars get out of whack. They don't feel it. It's because kind of the tissue damage affects on that, okay? And then post-op protocol, we have people, sometimes they get braces for comfort. We put them back to low impact aerobics at 4 to 6 weeks, and then we're having them return to the higher impact aerobics if that's something they're interested in at 3 months, and then full activity at 6 to 12 months. Lastly, when all options are exhausted, patient's been through surgery and they're still hurting, and we call it a failed back surgery syndrome. It's kind of a taboo term. We perform a thorough workup on those patients with continuing symptoms. Patients that have ongoing structural abnormalities, called depression or malalignment, may benefit from revision surgery. Most people are treated with non-operative pains if there's no structural cause identified. And sometimes we may get additional imaging such as a bone scan, which may be helpful. And that's it.
Almost it. Thank you, Dr. Reintjes. And as Dr. Reintjes explained, we take a multidisciplinary approach to back pain at North Kansas City Hospital. And an important component of that team is our incredible rehab department. And we have with us today, as Dr. Reintjes has mentioned, Kristen Evans is here. She is a physical therapist who works with our Move Plus program. So please join me in welcoming Kristen.
Thank you, Peggy. Can you guys hear me okay? All right, great. Thank you, Dr. Reintjes. He gave us some good examples of what your options are. What are your options with back pain, especially with ongoing back pain. So I want to talk a little bit further about our Move Plus program. Thank you, I'll need that. So our Move Plus program at North Kansas City Hospital. So I want to talk to you about let's say you go see Dr. Reintjes and then you guys decide that surgery is not necessarily the best option for right now, let's try some therapy. And he refers you to us for the Move Plus clinic. What that will look like is we'll have an evaluation. The evaluation will last, about 90 minutes or so, and we'll do a thorough assessment. We'll be having a discussion of, how you're feeling, and in that body chart that Dr. Reintjes had shown you where your circle and draw where you have your pain. That's really important for us as well. So we can have an understanding of where is the problem area and what can we do to show you the tools and to give you the strategies to help manage this on your own. So our Move Plus program is really designed for people who have ongoing chronic pain. So in the physical therapy realm, we have seen that managing ongoing pain with spine pain, we need to treat it a little bit differently. So the Move Plus program does that. And we have a progressive exercise program where we're helping you to get stronger, to restore function, to help get you back to doing what you were doing before. And the cool thing is this is covered by your insurance. So that's wonderful. With this program, we're using more of an active approach. So we're using our exercise, our stretching, and our education on helping you understand pain. And we've seen, and there's research that supports having an understanding of what pain means, especially with ongoing pain, can actually help you feel better. That teaching you about your body and what this means can help take away some of the fear that comes along with ongoing pain. And people that have pain and they've had it for a long time, they typically don't, exercise a lot, or maybe not move around quite as much as they did before because it hurts. So where physical therapy comes in is we partner with you, and then we help you progressively work towards getting back to the things that you enjoy and the things that you like through the exercises, through the stretching, and through the education. So we combine both it's a research-based method for helping restore movement with proven pain management strategies. The session itself is 90 minutes, and it's twice a week. So in totality, it's 8 weeks. So that is a big commitment, but we've seen that, especially with ongoing pain, the progress is usually slower with pain. But just because you've had pain for years doesn't mean that it can't change. It's just typically slower to change, so we have a longer program to allow that to happen. The sessions are 90 minutes. We have 30 minutes where we are working with you, having a discussion about this book that we work through. It's called Why Do I Hurt? It teaches you about how your brain processes pain, what pain means, and how we need to treat this a little bit differently with ongoing pain. And then we also have 60 minutes, an hour, where we're doing stretching, we're doing core strengthening, and then we're doing a progressive weight training program. The goal of this is we want to help get you stronger, help improve some of your endurance, because with ongoing pain, because it hurts to move around and we move around a little bit less, some of our strength is down, our endurance is down. So we want to address that. We want to address that through the exercise and stretching, but then we also want to give you the tools to manage this on your own. So essentially, we want to work ourselves out of a job. We want to show you what to do. We want to give you this program, get you comfortable, get you confident, empower you to manage this on your own, and then send you out and you can continue this program maybe at a local gym or with a trainer to maintain the progress in strength and endurance and also your pain management. So some examples of people that may be good candidates for this program. Now this is not an all-inclusive list. If you feel like you may be interested in doing something like this, definitely getting in touch with Dr. Reintjes and having an appointment with him and discussing this further. But some examples would be people who have failed conservative treatment. So conservative treatment meaning pain medications, or if you've done therapy before, or maybe just exercising on your own, going to your gym. You've tried some things and it just your pain is not where you want it to be. If you've had back or neck pain for more than 3 months, so we look at chronic or ongoing pain when it goes beyond that 3 to 6 month threshold. Once you cross over into that, then we look at it more into that kind of chronic ongoing pain. If you've noticed that you have limited mobility or flexibility, if your strength is changing, and then also if there's any stable but pinched nerves, that can be also a good candidate for this program. Some people who may not be appropriate are listed there. You guys can look through that list, some examples of progressed, if you have a pinched nerve that's progressing, or you have fractures, if you're not healing well after surgery, if there are unstable, or other types. Once again, that's not an all-inclusive list, so that's why it's important, if you feel like this is something you're interested in getting in touch with one of our physicians that are familiar with this Move Plus program and talking to them about it. And then they will help guide you in the decision-making process of, yes, this is great, let's try therapy, or maybe we need to go a different route. Some of the physicians that we have that are referring to our program are listed there. So you guys can take a look at that. You can see Dr. Reintjes, both senior and junior, are up there as well. And these physicians are all through the North Kansas City Hospital location. So that's great, a little bit about the program, but does it work? That's the important thing, right? So this officially started in January. When we put this data together, we had 16 people who have completed the program. So the 8 weeks, the 2 sessions a week, the 90-minute sessions, and you can see how that was distributed. We had 10 female, 6 male. The average age was 60, but if you look at the spread, so the spread was 38 to 78. Now that's interesting to me because ongoing pain is not really specific to a certain age group, that it can affect people all across the spectrum. And what's cool is that no matter what your age is, after meeting with the doctor and getting clearance for the program, that we can make improvements even if you're on the upper end of age or on the lower end. So that's pretty cool. And we saw that on average, people completed 14 visits. So the entire program is 16, but we gauge, how long you're in the program depending on your progress. We've had people that have done great and have finished early. So you can see that people typically finished a little bit earlier than what we had expected, but we have that program length to allow the time for that pain to change, because we know that it takes a little bit of time to change. It's almost like if you're exercising for weight loss, where you just start. You just start somewhere, you start exercising, and then after a few weeks or so, you notice that your pants are fitting different. Oh, I can fit into this dress I haven't worn forever, or those types of things. It's the same with pain. With ongoing pain, if we wait before your pain is gone, before we do any exercise, we're not going to do anything. Because it's been here for a while, and what you've done has not changed it. So we just need to start somewhere, and that's where we can help you. We can help you move around, we can help you exercise and stretch in a way that feels okay. And I've had really good success with finding movement that feels good, and then we can build on it. So that lays a good foundation for further movement. And that's where we can partner together to show you, well, you did this movement last time, so let's push it a little bit further. Let's push it a little bit further, but in a way that's tolerable. And I relate it to people who are training for marathons, right? They don't go out and run an entire marathon on the first day that they're training. They start slow. So they start running a half mile, and then a mile, and then a mile and a half. And that's the same thing that we do with our exercises here, where we start in a way that's challenging but doable, and it promotes improvements in your strength, improvements in your endurance, and then also that decreases the sensitivity with your body with movement. We've seen that people with ongoing pain, their body just becomes extra sensitive to movement. So with a graded program, like you would with strengthening and training for a marathon, we can help your body become less sensitive to some of the movements through exercise and stretching and also education. So further on into the outcomes, we've seen that a 37% decrease or improvement in their fear avoidance. So that's something that we assess on the first visit. There's lots of testing with numbers and bending and measurements, filling out of forms. We know forms are no fun, but we appreciate and they serve a great purpose for us, because then we have all of this data that we can come back to on our reassessments about halfway through the program and say, okay, we know how you're feeling, but let's throw some numbers in there too. Let's see how things are progressing from where you started out on the first day. So fear avoidance is something that when people are uncertain about doing things, like maybe if lifting and bending and picking up your grandchild is painful, and then you're not doing it because I'm going to pay for that later, that type of, I don't know if you guys have ever said anything like that to yourself, but having that fear avoidance improvement is big, because then you're less scared of your pain and you're less scared of hurting yourself. Because pain with ongoing pain doesn't always mean that you're harming yourself, which is something that we can help tease apart with you, that we need to attend to our pain, but part of ongoing pain is our system that's just become extra sensitive to movement, even normal movements. Turning and looking over your shoulder at somebody causing severe neck pain, right? So you had already met with Dr. Reintjes, and the spine is safe and stable and strong, so we're okay, we're safe to move around, so then we need to look at getting that system less sensitive to it. And then we also, you can see some improvements, the range of motion, so that's how much you can move your back around. That number just says that you're able to move your back around a little bit better, And, and then also the 6-minute walk test. That speaks to your endurance and your tolerance with walking. That when people completed this program, they were able to walk farther at the end than they could at the beginning, which is great. And something else, we have these numbers, but what are people saying about this? So you can read through some of these here. We've had people say that they felt 75% all the way up to 100% better. They can take less of their pain medication. They're returning to activities they were afraid of doing, like skiing. And they're going back to work after being off for 2 years. So some more testimonials here. They're able to lift their grandchildren again. And I like this one, flare-ups don't scare me now. That's important. That we've partnered with you and shown you, even if you do have a flare-up, this is how you can help manage it with some of these stretches and exercises. And then we can guide you on this is when it would be important to go back and meet with Dr. Reintjes, or try some of these exercises on your own for a little bit. And then also going back to activities like sewing, and then they had said, I would definitely recommend this to anyone. So we'd be happy to have you at our rehab department for the Move Plus program. If you feel like this is something that you're interested in or that you would like to find out more information about, please reach out to some of the doctors that we've had listed. And they would be happy to talk with you about it. We have more information on the front desk. When you guys leave, there's some flyers out there about the Move Plus program as well. Thank you.